It's Tuesday, November 5th, and this is the Daily Medical News, where we bring you clinical medicine's top headlines as well as an in-depth look at today's biggest story. I'm Molly Collegio.
And I'm Nick Andrews. Today, religious vaccination exemptions may just be personal belief exemptions in disguise.
Think Nocardia when patients with lung infections have brain abscesses.
Topical budesonide delivers in eosinophilic esophagitis.
And why value-based drug contracting isn't an easy solution to control drug prices.
Plus, researchers may have uncovered the missing links between childhood risk factors and adult cardiovascular disease. But first, we want to thank all of you who have helped make this podcast better by completing our short listener survey. If you haven't already, please do so. You can find the link to it in the show notes. And now, the top stories in medicine.
Religious exemptions for vaccination in kindergartners are lower in states with personal belief exemptions. But those exemptions appear to go up when personal belief exemptions go away. It's a phenomenon that may be caused by a replacement effect, according to researchers at Denver Health Medical Center. When personal belief exemptions aren't available, parents instead pursue religious exemptions. The researchers analyzed the CDC's yearly vaccine reports for kindergartners. The final analysis included data from the 45 states and the District of Columbia that all allow religious exemptions. It also included the 15 states that permit personal belief exemptions. The investigators found that the mean proportion of kindergartners with religious exemptions was lower where personal belief exemptions were available than they were where only religious exemptions were an option. States with both religious and personal belief exemptions were only a quarter as likely to have kindergartners with religious exemptions than those without personal belief exemptions. Given this seemingly paradoxical reported decline in religiosity and rise in religious exemptions, the investigators cautioned that religious exemptions may be an increasingly problematic or outdated exemption category. The findings appear in the journal Pediatrics.
A brain abscess in the presence of a lung infection should raise suspicion for nocardia, whether patients are immunocompromised or not. That's the cautionary message from researchers at the University of California, San Francisco. They presented study findings at the annual meeting of the American Neurological Association. Nocardia is a ubiquitous gram-positive rod normally found in standing water, decaying plants, and in soil. It can cause problems when inhaled as dust or introduced through a nick in the skin. And it's an underappreciated cause of brain abscess that's not covered by standard empiric therapy. The researchers compared 14 nocardia cases with 42 randomly selected staphylococcus and streptococcus cases. Contrary to the belief that nocardia infections only happen in immunocompromised patients, 29% of the nocardia patients were not immunocompromised. And patients with a nocardia brain abscess were far more likely to have a concomitant lung infection. The researchers' takeaway: start patients with a lung infection and a new brain abscess on empiric therapy, not just for pyogenic organisms, but also for nocardia, pending biopsy and operative culture data.
A swallowed form of budesonide to treat eosinophilic esophagitis aced all primary and secondary endpoints in a Phase 3 trial. Researchers at Northwestern University in Chicago say it's welcome news for patients with the chronic immune-mediated disease, for which no FDA-approved drug therapy exists. They presented the findings at the annual scientific meeting of the American College of Gastroenterology. The 12-week induction therapy study included more than 300 adolescents and adults who had failed to respond to at least 6 weeks of high-dose proton pump inhibitor therapy. They were randomized to 2 milligrams of oral budesonide or placebo twice daily. The histologic response rate was 53% in the budesonide group and 1% in placebo-treated patients. 53% of budesonide patients also saw a 30% reduction in their symptom scores, compared with 39% of controls. Adrenal function was normal in 88% of the budesonide group and 94% of controls. We'll be back after this message with more medical news.
Welcome back to the Daily Medical News. I am Nick Andrews. Paying for value over volume could be a key part of driving down prescription drug costs, but setting up a value-based contract can be a challenge. That's according to Dr. Diana Brixner of the University of Utah in Salt Lake City. Speaking at the annual meeting of the Academy of Managed Care Pharmacy, she outlined Utah's experiences with value-based programs. The state considered 3 options. The first option is value-based drug coverage, which pays for only those drugs deemed valuable by an independent source. The second option is outcomes-based contracting. The state works with manufacturers to determine appropriate disease states with verified outcomes measures. It then builds pharmacy contracts around them. And the third could involve zero copays for preventative medicines. But Dr. Brixner cautions that all 3 options come with potential disadvantages. With value-based coverage, patient advocates have argued that some drugs aren't cost-effective but are still the best choice for certain patients. And manufacturers worry about off-label drug use and its impact on a value-based contract. In the end, Dr. Brixner says different conditions lend themselves to different types of value-based contracting. For example, multiple sclerosis is better suited for a value-based drug coverage contract, while rheumatoid arthritis fits better in an outcomes-based contracting design.
There's plenty known about the relationship between cardiovascular risk factors in adults and cardiovascular disease. But Dr. Terence Dwyer says there's virtually nothing known about the relationship between those risk factors in childhood and later adult disease, until now. Speaking at the annual Congress of the European Society of Cardiology, Dr. Dwyer of the University of Oxford in England laid out direct evidence tying childhood risk factors to adult cardiovascular disease. The evidence comes from the International Childhood Cardiovascular Cohort Consortium, or I3C. I3C includes investigators from 7 pioneering prospective child cohort studies, which collectively measured major cardiovascular risk factors in more than 42,000 children beginning in the 1970s. Dr. Dwyer says pooled data from I3C provided the first direct evidence that high serum cholesterol, blood pressure, body mass index, and smoking in childhood are linked to increased risk of hospitalization for acute MI, stroke, and peripheral artery disease in early middle age. Specifically, the analysis showed that each 10% increase above average in serum cholesterol in childhood was associated with a 16% increased risk of hospitalization for a cardiovascular event at a mean age of 49 years. A 2-point rise in BMI was associated with a 20% higher risk. A 10% increase above average in systolic blood pressure in childhood was linked to a 40% increase in risk of a cardiovascular event in later life. And smoking in childhood or adolescence was associated with a 77% higher risk of a cardiovascular event. Dr. Dwyer cautions that the I3C analysis also demonstrates that exposure to cardiovascular risk factors in childhood has an adverse effect above and beyond that seen when the same risk factors are present only in adulthood. For a complete look at the I3C findings, click the link in the podcast notes. And that's it for today's Daily Medical News. If you like what you hear, please leave us a review or rating on Apple Podcasts. For MD Edge, I'm Molly Calagio.
And I'm Nick Andrews. Remember, you can find the Daily Medical News using Amazon Alexa, Apple Podcasts, Pandora, YouTube, or wherever you get your podcasts. Thanks for listening. We'll see you all tomorrow.